Well,
लॉन्ग टाइम नो सी. अच्छा है, बड़े दिन बाद मिल लिया आज
Hello,
वर्चुअली.
sir.
हेलो.
Welcome, Dr. Ashok Mehta. How are
I
you?
am Ashok Mehta.
हेलो
Actually, I am on a cesarean call. मेरे को 5 मिनट का टाइम है.
Right.
बोला कम से कम
So,
अटेंडेंस तो
so,
लगा ही
so,
लूं.
so, so we'll start 5 minutes. So let's formally start this event then. So good afternoon to all the faculty members, dear colleagues, and all the attendees. So on the behalf of Delhi IAP, I welcome you all on this obesity awareness workshop. So first of all, I would like to invite our chairperson, Dr. Ashok Mehta. He was a president of Chhattisgarh IAP in 2022 and currently an EB member of Central IAP. And he has a flourishing practice in Bilaspur. Welcome, sir.
Thank you, Mukesh bhai. I have met you in Raipur in couple of workshops and we had a very good interaction. And I'm very thankful to IAP Delhi for giving me the privilege to chair a session of the August faculties you have. And I welcome Dr. Smita, who is an MD Pediatrics and FIPAE, and she is a practicing adolescent and endocrinology practitioner. She has got a lot of presentations and lot of uh, publications to her credit. And I think you all know her. So without much ado, I would switch to Dr. Smita only to start with her talk and let the Sachin's back speaks.
Right.
thank you, sir. Thank you so much. I would like to first at the outset thank IOP, Dr. Mukesh, Dr. Sham, Dr. Lalit, sir, everybody for this opportunity. What we are trying to cover today is being the World Obesity Day. Is what are the latest things we are seeing nowadays? What has changed in pediatric obesity? And also, what is the need that we need to focus so much on pediatric obesity? So, going forward, first of all, obesity is a chronic disease characterized by excessive or dysfunctional adiposity in our body, which leads to a lot of health problems.
there is some disturbance there. Some disturbance is there. सुशील, किसी को ऑफ करो. I think some disturbance is there. Now it's okay. Please.
Dr. Bhavna, your mic is on. Yeah, sir. So, yeah. So, like I said, what is the need that we need to focus so much on pediatric and adolescent obesity? There has been an alarming increase in the prevalence in obesity in children. And also, there has been volumes of understanding of the pathogenesis, the risk factors, and much more management options are available now to us. So, this is the latest NFHS data of India, which shows that below 5 years of age, 3.5% has been the obesity, of which 4.2% is in the above, which is almost at 50% increase from the large NFHS data, which is just was 2.1%. Similarly, the pool data for childhood and adolescent obesity has also increased from 16.3% to almost 19.3%, which was last taken in 2010. So we know the increase has been more, and we've all seen that post-COVID, due to the lockdown and everything, the jump in number of pediatric population, not just adolescent, with obesity has gone up alarmingly. So, how do you, most importantly, what I will be going through is the AAP came out with childhood pediatric obesity guidelines in 2023 January. And then our own IAP and ISPE together got down with the and revised guidelines for pediatric obesity in December 2023. So I'll be highlighting what is the newer things in that, what are the changes in classification that's been done, and what are the changes in treatment modalities pharmacologically that we can do now. So they have broadly classified obesity into exogenous, which is primary obesity, or obesity due to lifestyle problems. So this is a massive amount because this accounts for almost 90%, more than 90% of all cases of obesity. Then comes the endogenous obesity or secondary obesity that they call, which is due to a secondary cause, of which endocrine causes are usually just less than 1%. So the bulk that we're facing is lifestyle associated primary obesity. So what is exogenous or primary obesity? What are the risk factors? So parental factors play a huge role. So when they say parents are obese, what does it translate into clinically? So if your one parent is obese, your chance of having a child developing obesity is almost 40%. And if both the parents are obese, your chance of obesity goes up to 80%. There are prenatal factors which play a role here, like maternal nutrition, maternal diabetes, excessive weight gain during pregnancy, any placental disruptions, and especially babies who are SGA or IUGR. Lifestyle factors, we all know, we all have been dealing with these problems with kids. Inadequate physical activity, poor sleep pattern, and the biggest culprit, which is again emerging over the last couple of years, is excessive screen time. This is one of the biggest demons that we're all facing as healthcare professionals and as parents. Yes, dietary. So in dietary factors, what you also have to remember is parental eating habits, behaviors play a huge role. So you cannot expect a child to eat healthy if everybody else in the house is eating unhealthy. So that is one thing. Overfeeding. So the tendency to overfeed babies who are preterm, SG or IgA is still very, very prevalent. That also is a cause of increased pediatric obesity. Prolonged and early exposure to formula feeds, prolonged bottle feeding, junk food. Junk food is junk food, which is high calorie, nutritionally inappropriate, ultra processed. Any carbonated, colored, high calorie food or drink is considered as junk food. And the habit of nocturnal snacking. They stay awake later, they're watching their phones, and junking is also a leading risk factor for primary obesity. And then, of course, environmental policies, in which the biggest challenge is the commercials for HFSS, which is foods high in fat, salt, and sweet. So these are the things that we need to look into. Then, of course, we come to the endogenous obesity. So what I would like to reiterate here is, like I said, more than 90% is your lifestyle associated primary. It's less than 10% that you would find that there is an underlying secondary cause to obesity. Endocrine causes constitute less than 1%. The common is hypothyroidism, Cushing's, growth hormone deficiency, pseudohypoparathyroidism. Monogenic lesions causing obesity are very rare. They run in families and they have more markers like your melatonin 4 receptor deficiency, leptin deficiency, or POMC deficiencies. These are, but these again, the numbers are very, very less. Some syndromes are associated with obesity, the commonest being with Prader-Willi, Bardet-Biedl. I think Prader-Willi we'll be talking about following this talk. Neurological and hypothalamic causes have known to be associated with obesity, especially any space occupying lesions, infective lesions of the brain, surgery, trauma, any of those things. Children on long-term drugs, the keyword here is long-term, can become overweight or obese, especially those on depressive disorders, eating disorder, anti-epileptics, antipsychotics, sulfonylureas on long-term. Psychologically, problematic children who have issues can also lead to weight gain because they have a tendency to binge eat. So these children also need to be watched out for. Of course, there is a whole bunch of miscellaneous reasons, especially children who are in the autistic spectrum, attention deficits, children with special needs. They're also a bit more prone to becoming obese or overweight. So how do you define obesity and what do you use for defining so? As you know, we all know the most commonly used diagnostic tool for screening, grading, follow-up is your BMI, which is weight in kg divided by height in meter square. We all know this. It's easy to use. It's easy to calculate. It strongly correlates with your DEXA measuring of fat. And it is also good, easy to follow the trajectory. So what were the BMI cutoffs? WHO says for children between 5 to 18 years, more than 85th percentile is overweight, more than 95th percentile, that is plus 2 SD, is obesity. So these two cutoffs of overweight and obesity translate to on the BMI chart 25th for overweight, and beyond 30 kg per meter square for obesity. However, the IATF and WHO has suggested for the Asian population, the cutoffs are different. 23 on the BMI chart is equivalent to overweight of the adult equivalent. 27 of the adult equivalent is equal to obesity. Why? That's because adiposity is more in the Asian population, and at lower levels, we are at risk for more cardiovascular complications. So the cutoffs for the Asian population is 23 and 27 for overweight and obesity, respectively. In these guidelines, what they have come up with is they've redefined severe classes of obesity. We've seen overweight and obesity. They've divided obesity further into class 2 and class 3. Class 2 is when obesity is more than 120 to 140% of the 95th centile, or your BMI is more than 35 and less than 40, whichever is lower. And class 3 obesity is when your BMI is over 140% of the 95th centile, which is over the 40 of BMI, or whichever of these is lower. For children 2 to 5 years of age, IAP growth charts are not available, so we recommend using WHO for height length charts. The overweight cutoff is more than 2 standard deviation for overweight and more than 3 standard deviation for obesity. So BMI is a great tool. However, there are a few pitfalls which it has that we should be aware of. BMI does not directly assess the body composition. It has low sensitivity when you have to test for body adiposity. That means a fat. So it is not valid equally across all genders, age, and groups and ethnicities. Second, it is a measure, value which will not differentiate between your lean mass and adiposity. So again, fat and muscle will not be differentiated. So it alone is not an absolutely great marker for abdominal adiposity and can hence be not very useful to detect cardiovascular risk. So what do? We add on another simple method that we can all do sitting in our clinics with no special equipment, which is waist circumference. So the combination of BMI and waist circumference done is superior to BMI alone. So why waist circumference? It is very, very simple. You do not need to apply anything clinically. Non-stretchable tape is which is required. A combination of BMI and waist circumference identify high-risk phenotypes superior to either one of them alone. It also is a good measure for visceral adiposity, which we've known has higher risk for cardiovascular dysfunctions. And it has a strong association for metabolic syndrome also. What you should use when you take waist circumferences, India-specific charts for waist circumference in children are available. We should use it. WHO used to recommend more than 90 centile as a risk factor. But for screening purposes, more than 70th centile of waist circumference is used as the cutoff as an indicator of obesity. So like I said, the two of them together, BMI and waist circumference together, gives a better measure of the risk factors. So what are the red flag signs that you should watch out for when you know that you need to work faster, you need to look into more, and the child needs to be investigated? So any early onset obesity, that means in the first few years of life, there's excessive weight gain. It's a big red flag sign. Another thing that any child who walking into my clinic is any child who is overweight and short, there's a very, very high chance that the child has an endocrine dysfunction. So this is one of the biggest red flag markers for anybody. Overweight child who's faltering for height should be evaluated for endocrine issues. Hyperphagia, non-discriminatory. What do I mean by non-discriminatory hyperphagia is any child who has a tendency to keep eating frequently. He's just finished a meal and he wants to eat again. Non-discriminatory means not binging or eating on the foods he likes. So normally children tend to eat when they're hungry, biscuits, chocolates, junk foods. No, non-discriminatory is a child will eat anything from a ghia, tori, cucumbers. So that is non-discriminatory. He will just go on to eat anything. This is a big, big red flag sign. Any dysmorphism that you noticed can be associated with a syndromic cause of obesity. Developmental delays, vision abnormalities, and behavior problems should be clues that we should watch out for. Any history of drug intake, especially children on steroids long term, should be worked up. Also, if you get hypogonadism, microgenitalia with obesity, these children are another set of children who need to be worked up. So any child walking into your clinic, oxology becomes extremely important. Your Tanner staging becomes extremely important. So what is the workup, the initial workup? Like I first said, the first and foremost is the oxology. Your height-weight ratios, is he falling for short or not? Crossing of centiles, is the child been crossing centiles? The waist circumference. Then comes the pubertal staging. Pubertal staging, two things that you need to rule out is lipomasia. You need to see for lipomasia, differentiate it from gynecomasia. Buried penis and micropenis. There are two separate things. Buried penis is a lot of times seen in children with obesity. So when you do a stretched penile length, you rule out the other. Any hypogonadism associated with undescended testis, delayed or precocious puberty, both can be seen. And then you go on to examine the skin. This is one of my kids I've been treating for obesity with severe acanthosis nigricans. This picture is mine. So acanthosis nigricans is another thing that we need to look at. Hirsutism using a Ferriman-Gallwey score. Any wireless striae, which can be seen on the skin, which are usually seen with hypercortisolism. Xanthelisma, skin tags indicating hormonal and lipid abnormalities. And of course, when you look at the child, you make it a habit to look at the hands and feet to see any polydactyly, syndactyly, any features of dysmorphism, which can point to an underlying syndrome. So a lot of times, once you examine the child itself, you will get a fair idea if you're dealing with primary or secondary obesity. So for exogenous obesity or primary obesity, what is the workup that you like to do? A fasting lipid profile, ALT, renal blood test, fasting blood sugars, a oral glucose tolerance test, and a glycosylated hemoglobin HbA1c if it is indicated, if you see severe acanthosis, deranged parameters, then. So if you feel it is not nutritional, for secondary causes of obesity, first and foremost, hypothyroidism, rule out Cushing's. Cushing's can be ruled out with serum or salivary midnight cortisol, 24 hours urinary free cortisol measurement. Confirmation sometimes can be done with a DEXA suppression test. Growth hormone deficiency, because these children typically present with short stature, obesity, which can be done with a bone age, a growth hormone stimulation test, and IGF-1. Pseudo-hypoparathyroidism, these children may present you with bowing features of hypocalcemia, calcium, phosphate, IPTH, X-rays will give you a clue. If there is a family history, if there is syndromic, then you should consider specific genetic testing to rule out monogenic. And of course, if you're suspecting a CNS cause, a hypothalamic or pituitary cause, you could go for the MRI brain. So other than this, what other methods are there to find out about adiposity? So we have two methods, the dual energy X-ray absorptiometry, which is the DEXA, or the BIA, or the bioelectrical impedance analysis. So DEXA is highly sensitive and specific for detecting fat in the pediatric population. It's very accurate, low dose, it's fast. It has low dose radiation, easy to use. However, it's expensive. The results are operator dependent, and there are not enough standardizations of the machines and software to detect the values. What can be used is a BIA, which is a bit less accurate than DEXA, but it is portable, it's cheaper, it's relatively easier available. But again, DEXA and BIA, it would be recommended in cases where there is severe obesity, who you feel are 3 or 4, or associated with a lot of complications. So when do you consider a genetic testing? Another modality which is coming up very fast, which has been widely used to assist us with diagnosis, is you should have a low threshold for genetic testing when there is a family history of consanguinity between the parents. The onset of obesity is early, that is less than 5 years in kids, associated developmental delay, growth retardation, any dysmorphism, any congenital abnormalities, hormone deficiencies, or vision deficiencies. So these are the conditions where you should probably earlier think of genetics. Why does it help? Because it is important to helps you to prognosticate, counsel the parents, and also lays out a few more of therapeutic options that you may have in leptin deficiency conditions. It helps. So another point I would like to touch upon is when we're talking about obesity is the prevalence of metabolic syndrome in Indian children, which is also rising. So as per the IDF data, metabolic syndrome in children aged between 10 to 16 years, they have a criteria. The prevalence is around 13% in over 13% in overweight children and over 46% in obese Indian children between 10 to 18 years of age. Only pitfall here is there are no absolute criteria to diagnose children below 10 years, and below 10 years is also a good amount of population where we're getting obesity. So metabolic syndrome is when the abdominal girth or waist is more than 90th centile for age, gender, and ethnicity. Sorry. So ethnicity ke liye there are India-specific growth charts for waist circumference. We should adhere to them. That with any two or more of the following of hypertriglyceridemia, fasting glucose plus than 100, systolic BP more than 130, and diastolic less than 85, basically more than 25th centile for adjusted for age, height, and gender. So this is the criteria to diagnose children with metabolic syndrome between 10 to 18 years. So what are the comorbidities that you should also be screening other than your first level of screening that you do? Dyslipidemia screening should be done. The AHA recommends screening obese children between 9 to 11 years, and the second peak that you should screen is between 17 to 21. A fasting lipid sample is preferred for screening. Diabetes, it is also on the rising trend. The number of children who come with pre-diabetic numbers have gone up because of obesity. So ADA recommends screening at 10 years or pubertal, whichever is earlier, in the presence of obesity or risk factors. Or in fact, if the symptoms itself present earlier. Non-alcoholic fatty liver disease, also called as metabolic dysfunction associated with liver disease. The prevalence is also very high as 34% in obese children. So what they refer to is the safety guidelines prefer ALT screening should be done. The normal value is less than 26 in males and 22 less in females. Why are these values important? Most of the times when they come to with reports, they have the lab values which will say 35 or 45, and the parents are very happy. You have to tell them, it is important to tell them that you may have early fatty liver diseases. It helps them sensitize them to the severity of the problem. So when they say a value and you tell them a diagnosis, they are more motivated, both the parent and the child, especially when you know that these are reversible. Hypertension, it has also a very high prevalence, about 5 to 30%. AAP says in childhood hypertension, screening should start at 3 years in children who are at high risk factors. Hypertension is stage 1 and stage 2 as given by the AAP guidelines of 2017. Another problem that is coming is obstructive sleep apnea, which is almost 45% in these children versus 9% in non-obese. It is screened by using a polysomnograph. Obstructive apnea will not also be very clear. Sometimes children can only come with the fact that they are snoring and they wake up recurrently at night due to bad dreams. So it's not actually bad dreams. It's probably this child is having repeated episodes of obstructive sleep apnea. So they'll be tired throughout the day. They will have interrupted sleep. These kids need to be evaluated also. Then, of course, a very, very increasing number of PCOS is seen in adolescent girls associated with hyperinsulinemia and hyperandrogenism. It is a cycle which obesity leads to it, which needs to be broken. Otherwise, the cycle continues to develop PCOS. which makes losing weight even more difficult, and the cycle continues. Of late, the adolescents and children with obesity, with depression is increasing. This is associated also with a lot of peer pressure, bullying because of overweight children being overweight. Idiopathic cranial hypertension, it's mostly seen more in girls. And of course, CNS symptoms of headache, tinnitus, visual changes should also be screened for. So coming to management of obesity, easier said than done. The biggest challenges I think any of us face while trying to manage a child with obesity. So the goals are A, to decrease your adiposity, alleviate the physical stress with it, manage and address the psychosocial comorbidities, halt the progression of the chronic weight gain, and also support the child to long-term maintain. It's easier to lose weight. What is more difficult, what I always say, is to maintain it. So it has to be a holistic approach of lifestyle changes which needs to be dealt with. What are the management options? Always, I would like to say, in the pediatric population, lifestyle modification is first and foremost. Dietary management, physical activity, these three constitute the first line and the most important line. These will be discussed by Dr. Bhavna later. Pharmacological management comes in only when your first three have failed. There are, significant risk factors and the health of the child is compromised is when in children you will go forward with pharmacological management. The options are limited and only beyond 10 to 12 years of age. So below that, pharmacological agents are not advised. So the couple of drugs which are FDA approved that have been used are metformin. Metformin is used only for not for primarily the treatment of obesity, for insulin resistance and diabetes beyond 10 years of age. So this should be used when you're suspecting severe acanthosis or PCOS or those things are associated with obesity. This is a good option beyond 10 years of age. Orlistat is a GI lipase inhibitor, which prevents fat absorption, which can be given again beyond 12 years of age in obese or severely obese children. The latest, one of the newer drugs, which has joined the group of pharmacological agents for obesity in children is semaglutide. Semaglutide has been approved for obesity again in children beyond 12 years. It's a GLP-1, which decreases gastric emptying, suppress the appetite. The approved formulation is an injectable, which is given subcutaneous weekly. However, what I like to bring to your notice that semaglutide, the oral preparation has also been launched a couple of months back, approved in adults. Again, older adolescents, young adults, the data is there. For children, the data is still yet to be published. So if given, should be only for older adolescents and early young, not before that. Also, phentermine and topiramate have been approved, but in very, very specific cases, and that too beyond 16 to 18 years of age, not before. So this is an algorithm which has been put up by the ISPE guidelines where, they've given you a chart on how to classify children based on obesity and how to treat them. So lifestyle modification should be at least tried for 3 to 6 months before you even consider pharmacological agents, because that's the time it takes to get your lifestyle changes, resulting in a decrease in weight and BMI. If that is after ruling out your secondary causes, and then you may advance to pharmacological agents. And in case of severe life-threatening obesity or severe complications, you might need surgeries. So the take-home message here is there is an increased rising prevalence of both infantile childhood and obesity and adolescent obesity. And the problem needs to be addressed by healthcare professionals. There is enough proof that childhood obesity leads to problems in adulthood, both cardiometabolic and psychological. Obesogenic environment needs to be altered because it encourages weight gain and it's not supportive of weight loss. So the family needs to be primed and counseled, because weight loss programs or modifications cannot be applied to the child in isolation. Genetic obesity must be suspected when in an infant less than 5 years with severe obesity. But most importantly, what we need to remember is while managing obesity with any of the parameters, there is no one size fits all approach. It has to be tailor made and titrated to each child's dietary pattern, physical ability, and home and school environments. I think that is all from my end. I think we can go on to the next or take up questions, however the host feels.
Right. Thank you, Dr. Smita. It was a wonderful talk. We know we should prioritize ourselves. We should avoid obesity, but somehow once it comes, just doesn't go. ये रहता है. I don't know how to deal with it. I would probably need some counseling from you and some advice. Over. Dr. Ashok.
Dr. Smita had a very nice talk on obesity. I just want to know, Dr. Smita, ये waist circumference के chart you have, where are it available?
So there,
India.
IAP के Dr. Khadilkar charts are there. It's freely available online.
Oh, no, waist circumference chart.
Waist circumference. It's online available as a freely. I think in IAP, one of the publications, it's been published in the IAP. So these charts are available. So if you just Google it, you will get them, sir. Indian charts by Dr. Khadilkar.
And secondly, what is the role of anti-obesity drugs you mentioned? आप लोग use कर रहे हो practically?
See, so like I said, first and foremost, the first 6 months should be lifestyle modifications, because even if you make the child lose weight, if you've not modified the lifestyle and eating patterns, he'll gain it weight. Yes, older adolescents and younger adults, who have they're very, very obese, like category 3 and 2 and 3, who've tried everything and not losing. Yes, pharmacological agents, metformin and semaglutide are being used, but not very liberally, in case-to-case basis.
Right. And in Indian population, which are the commonest cause? It is the primary only, and what are the secondary? Which is the secondary important cause?
The most common cause is nutritional. So out of 90% who walk into my case, I have hardly found. So the common perception is it is hypothyroidism. It is very rarely hypothyroidism. Your hypothyroidism has to be quite deranged for you to be so obese. It is a secondary reaction to obesity most of the times. So hypothyroidism and sometimes hypercortisolism, mostly drug associated. Yes.
Thank you. Very nice presentation. Very nice.
Right. Let me take this opportunity to invite Dr. GP Kaushal sir. We could not welcome him at that time. Kaushal sir, good afternoon. And Dr. Pankaj Garg also. Pankaj Garg sir, good afternoon.
Good afternoon, sir. Good afternoon.
Right.
We have Central IAP is also conducting the same program.
कोई नहीं sir. Omnipresence everywhere.
थोड़ी सी
Right.
attendance कम है हमारी attendance.
Right,
It doesn't
Right,
matter, sir.
Right, sir.
Thank you.
So, Dr. Ashok, are you there, or should I invite the next speaker? Probably he's busy in that other meeting. So, so for our next talk, we have Mrs. Shikha Mehta Ramani. I hope I am pronouncing this correctly. So she is a founder and president of Indian Prader-Willi Syndrome Association. She is also a committee member of Organization for Rare Disease in India. And she would be talking about her journey and mission with these conditions. So over to you, ma'am. Welcome.
Thank you, doctor. Very good afternoon to all the respected doctors attending the meeting today. I hope I'm audible to everybody.
Yeah, you're audible.
I thank IAP Delhi for thinking about Prader-Willi syndrome and including this today knowing the relevance of this topic in the pediatric community, because for me this is a very important talk because I've always felt that pediatricians are the first point of interaction a parent goes to with their child. And the recognition and our main mission to start Indian Prader-Willi Syndrome Association was early intervention, early diagnosis, and to help the child and the family for better treatment of the children treated with Prader-Willi syndrome. So as you know that Prader-Willi syndrome was mentioned by Dr. Smita in the last presentation. And I'll very briefly say, since most of you must be aware, it is a genetic disorder that causes obesity and intellectual disability. And there is a shortness of height. Prader-Willi syndrome occurs, it's a genetic disorder usually caused...
Dr. Shikha, would you like to share some PPTs, or you would be just speaking like this?
There was a PPT which I had shared and with the...
No, it's fine. If it's fine, you can go ahead. I thought probably we
So
we are
PPT
missing.
was shared and it was supposed to be played actually while I was talking. I don't know. Somebody had contacted me from IAP and I'd shared the PPT with them. I don't have it on this laptop actually.
Okay, go ahead. I'll try to do that. Okay, go ahead.
So Prader-Willi syndrome is caused by a deletion part of chromosome number 15. Now, as I said, the importance of this seminar for IPWSA is greatly because of the pediatricians attending this meeting today. Pediatricians can diagnose syndrome at a very early age, maybe at a neonatal age, but in our country, we have seen an average diagnosis age of 7 years. Whereas in PWS, we can actually see that the diagnosis outside in the West is made below the age of 1 year. With the kind of work our association has done in the last 2-3 years, we have seen many patients which are in India being diagnosed as below as few months age or less than 1 year. Now the red flags to diagnose PWS is neonatal and infantile central hypotonia, which obviously gets better with age and physical therapy. They have feeding problems and poor weight gain in infancy, excessive rapid weight gain between 1 to 6 years of age. So the children who are born with PWS are usually born at a very low birth weight, and their weight gain is very rapid. Initially, they have feeding problems and functional problems. They have delayed milestones, but once they turn the age of 3, their food-seeking behavior pattern starts. So, if any pediatrician comes across a child which they notice has these characteristics, they could suspect them for PWS. Another thing which is noticed, which is mostly in 95% male PWS children, is hypogonadism and undescended testis. So if there is a child who is born with hypogonadism, undescended testis, a male child, and having all these symptoms, that again gives them a very clear clinical diagnosis to test them for Prader-Willi syndrome. Few things which can be said: they have a global development delay before the age of 6, and they have mild to moderate mental retardation and hyperphagia, which starts after 3 years. They have a high pain threshold, and they also have thermoregulation issues. Some minor findings in these children are skin picking issues, and skin picking issues get more and more worse with as they grow older. Skin picking issues is also related to the psychological behavior of the child, and it has to be monitored and assisted by the family. So what happens if you come across a child who is showing all these symptoms which actually direct them to have Prader-Willi syndrome? So what is to be done is that they should be sent for genetic counseling, and they has to be there. Pediatric endocrinology should be consulted after the diagnosis, because they have to monitor the pituitary and hypothalamic functions. Then there are growth hormone deficiency in most of the PWS children. And even now in the West, even if there is no growth deficiency, growth hormone is administered to children with Prader-Willi syndrome for multiple other benefits: cognitive development, muscle mass development, and the fat mass is transferred into muscle mass. So that is the things which have to be looked out for, and the endocrinologist should immediately intervene. A pediatric endocrinologist should be referred to for any child with PWS. So Prader-Willi syndrome is divided into 3 stages in their life. The early childhood stage, which is mainly about involving therapies: physical therapy, occupational therapy, and speech therapy. The children have delayed milestones, and the pediatrician has to make sure that the child is going through all these therapies once they are stable and they start breathing and eating properly. Not eating properly, by that I mean that all of them have sucking and swallowing problems, and when they are born, and right after birth, most of them are on the rice tube and they are fed by that. So once they outgrow that, then the therapies should start for the early life of PWS children. Side by side, one should also look at growth hormone treatment, which is now well accepted in India as well. And there are many, it is an expensive treatment. So a lot of government hospitals, as per the National Rare Disease Policy, is providing this treatment free to PWS children. So this is something about Prader-Willi syndrome, which most of you all are aware, but I just thought I should brief everybody once again about this. Coming back to what we do as a parent support group. Prader-Willi syndrome is, Indian Prader-Willi syndrome was founded by parents of Prader-Willi syndrome children, and it's a patient support group to spread awareness and knowledge about PWS. We provide support and guidance to families to improve quality of their life, of the caregivers, and also the individuals of PWS. A little bit about me is that I'm a mother of a 20-year-old child with Prader-Willi syndrome. And my son Ansh was diagnosed in America, in United States of America, in the year 2004. With a lot of failed attempts of multiple different diagnoses, I finally had to take him to USA for his treatment. And that is where he was diagnosed by an Indian neurologist, a pediatric neurologist, who said that my son has Prader-Willi syndrome. It was a term which I'd never heard before. And that is where I decided to read more about this, because I come from a family which has a medical background, and I was told to intervene and see what can be done, rather than just thinking and sulking that why my child is suffering from this disorder. That is where I wrote to the International Prader-Willi Syndrome Organization, and they invited me to attend multiple of their seminars in the United States, in Australia, and various parts. That was when I discovered that like me, there are many parents in India who are struggling to get diagnosis of their child who might be having a similar issue. And I have to come back to India and talk about and spread awareness about this syndrome. At that time, I connected with few doctors in India, and we started taking part in CMEs. The first CME which we held was at a hospital in Calcutta called Bhagirathi Neotia Hospital, and it was done by Dr. Apurva Ghosh sir, who was fortunately my son's pediatrician at that time too. And he is the director of the Institute of Child Health West Bengal also. So at that CME, we presented my son's case history. And after that, there was no looking back. There were multiple pedicons we took part in, and there were speakers who came from outside India to speak on Prader-Willi syndrome. And the numbers of PWS families grew. Now, today, we are a large family of 200 plus parents and of patients who are connected with us on a WhatsApp group, and we provide them with the smallest problems that they have in their life to the biggest achievements that our children are doing as well. So this WhatsApp group keeps us motivated to help each other, to talk about our feelings about the child, about how to bring up the child, which of course a doctor is doing their duty as giving them the medical guidance. But as parents, they have multiple questions, which I know because being a mother, which I had faced when my son was diagnosed in America. So I do not feel that those parents should be left alone. Now we have a very energetic team from Bangalore, and we have a parent from Ludhiana who is also a co-founder with me, Mr. Rohit Nagrat. And from Bangalore, we have Sri Harsha and Mr. Michael, who are heading the group as committee members. And IPWSA is functioning all over India, trying to help the patients. What we provide to the patients are free testing facilities. Then we have achieved in getting free growth hormone treatments in West Bengal and in the state of Karnataka through government sponsored funds. We are really trying to navigate our way through other states as well. Hopefully that should be achieved. We've also managed to get Prader-Willi syndrome noticed and mentioned in the National Rare Disease Policy. Then in the last few years, we have done orthopexy free surgeries for some patients under the government schemes. We have provided CPAP machines to multiple children who have obstructive sleep apnea. Then there are events, periodical events that we do. Our last event being the one which was done by Aster Hospital in Bangalore under the guidance of Dr. Kavita Bhatt, which was on December 16th. So these are the events that we have done. The relevance of a patient support group in India came much later than the West because of multicultural issues in our country. Especially which we have seen in north of India is that there are the patient support groups are much more active in east and south. But in north of India, typically we have seen that the parents are living in denial, or they want to hide the disease from their because of social stigma. So these are the reasons why PWS is not very widely. We do not have a proper database through which we can actually make a collective voice to have more and more clinical trials and pressurize the government to do better for the patients of PWS. Here in this platform today, I would request all the attending pediatricians to forward and encourage their PWS patients to register with our organization so that we can today, and for the future, work as a collective voice from all Prader-Willi syndrome parents for a better future of this PWS generation. We all know that PWS does not have any cure. So a lot of parents also feel that if there is no cure, then what is the point? And what is going to happen after us? So we try to tell the parents that, with better treatment, we can give the children a life which is at peer, as normal as their peers. And PWS children are very loving children. We can make them achieve a lot of things in their life. Personally, my son is an artist. His paintings, very recently, I have submitted his paintings for an art show in the National Museum, New Delhi. And similarly, there are other children in our group who are really achieving. Some have taken part in swimming competitions and marathons and doing very well in different parts of their life. So that is why we tell their parents that please do not give up and do not lose hope. There are a lot of parents who are doing well for their PWS children, and together, if they join the community, we can motivate each other and we can do much better for them. Now, coming back to Dr. Smita's talk on the entire house eating habit. This is something which, as an organization, we try to tell that when a child has PWS, it's not the child only who has PWS. The entire family has PWS, literally, because that is just a term which we are using, because you have to understand that the eating habits have to be good eating habits for the entire house. It is not just for the benefit of the child, but the healthy eating habits and the kind of future generation that we are looking at. Everybody is being aware of good eating and diet management in their house. So with proper diet management and good eating habits, we can encourage our children to have a good lifestyle and physical exercises, and motivate the PWS children once they have finished with all their therapies to start growth hormone, to have proper education levels like special education, which my son has passed the National Institute of Open Schooling, and most of our PWS children have passed class 12 from National Institute of Open Schooling. Some are in college and pursuing higher studies as well. So they can look into studies, they can look at regular physical activities, engaging them in swimming, dancing, cycling, etc., etc. So these are the things, and the parents should participate with their child and not just sit and say that, okay, you have PWS, you have to do all this. No, we all have to be fit, we all have to eat right, we all have to be healthy. So this is what our group is working for, is total family counseling, parent counseling, supporting each other. And our motive is that there are more clinical trials in our country, and the parents get more support from the government. Another thing which we are also fighting for is children with rare disease and PWS, including that, do not get general insurance, medical insurance benefits. So this is another advocacy that we deal with. Something Dr. Smita had mentioned regarding semaglutide is another new study, which we would also like to direct to the endocrine doctors present today in this meeting, that if they could elaborate more, because that is a question a lot of adult PWS parents have spoken about, and we have got very contradictory statements on this, and we are very interested in knowing more if that can be helped in PWS children, or there can be a clinical trial done in India with semaglutide and PWS children. So I would like to conclude that if any of the doctors present here today see clinical features which directs the child to be suspected as PWS cases, and if the parent is having affordability issues, there are many laboratories, private laboratories available who are doing the genetic testing, or the genetic counselor can refer them to us. If the patient have affordability issues, we can provide them with help, financial assistance to get the test done. There are certain free clinics which are providing PWSS, which are government clinics. At AIMS, the test can be conducted, or at Gangaram, they can go to Dr. I.C. Verma's clinic, where the test was conducted earlier. Now, during 2004, when we had first started Indian Prader-Willi syndrome, these tests were not even conducted in India. There was probably an entire chromosomal study which was done in 2 laboratories all over India. And at that time, the International Prader-Willi Syndrome Organization helped us. And I remember taking blood samples, drawing it into a Whitman filter paper, and sending it to Italy for the test to test these children. The reports would take 4 weeks to come. But now in our country, the PWS testing facilities are very easily available. And if the child you all feel has any of these clinical features, please refer them to us, or refer them to a genetic counselor who can get these tests done. And also, if you all have a child with PWS already, they should go to a pediatric endocrinologist for treatment and regular follow-up. And there are certain guidelines and tests. If you all require, I can also share certain brochures and red flags to clinically diagnose a PWS child, which has been there as per the international standards, and we can take forward from there. I would thank you again, the entire group, for having me here to speak about Prader-Willi syndrome. I've not made it very long, and my presentation here is not played due to some technical reasons. So thank you again, and I just hope that there is, with help, there is better hope for Prader-Willi Syndrome Association and our children for future. Thank you.
Right. Thank you, Mrs. Shikha. Inspirational. Your journey is really inspirational, and we will definitely be in touch with you, and definitely some of the Prader-Willi kids would be benefited by you.
Thank you.
Dr. Lalit, Dr. Kaushal, would you like to say something?
Sir, Dr. Shikha, this is a wonderful initiative you have taken. I would like to know that I think one of the things we can do, IAP Delhi, is that one of the admin from IAP can join your WhatsApp group, so that anybody who wants a Prader-Willi syndrome associated problems, he can directly in contact with you, the parents. You already have a WhatsApp group.
Yes, sir. I think that would be a great initiative.
Mukesh, I think Sushil can be a member of that.
Yeah, Sushil, fine.
So that anybody who has this, like we have a Down syndrome group, similarly we can have a PWS group. So anybody, parents, once any pediatrician diagnose or suspect PWS, then we can direct them to this supporting group.
Yes, sir. That would be very, very good initiative, because they'll get first-hand. In fact, recently we have had 3 pediatricians whose children have had PWS, and they've joined our group. They are from Gujarat. One unfortunately lost their 8-month-old baby 2 years ago. because the child was given administered growth hormone without conducting a sleep study, and the child passed away in the sleep during sleeping due to some issues. So we just feel that even growth hormone cannot be administered very loosely. A proper sleep study has to be conducted under the supervision of an endocrinologist and a pediatric pulmonologist as together to take a decision on growth hormone.
One more thing, where are you getting the genetic study done from? Which?
So MedGenome is there. Actually, in Calcutta, SSKM Polyclinic is conducting the test free. And in Delhi, I have seen that a lot of people go to Dr. Ratnapuri in AIMS and Dr. Madhulika Kabra, and it is conducted through AIMS as well in Delhi. But privately, we can do it from MedGenome. They are doing it they are doing at a concessional rate, and there is PerkinElmer. That's also got a concessional rate for PWS parents. I think they're charging 6,000 rupees. There is also Kamineni Hospital in Hyderabad, which is doing the tests at a very concessional rate of 1,500 rupees.
So Delhi, we have AIMS and MedGenome, right?
MedGenome is there. PerkinElmer is also there, sir.
Okay. Thank you.
Thank you.
Thank you.
So thank you, Mrs. Shikha, for this wonderful talk. For the next talk, I would request Dr. Shyam Sundar Meena to invite Dr. Bhavna Anand for the next talk. Over to Dr. Shyam Sundar.
Thank you, Mukesh. I would like to invite Dr. Bhavna Anand for regarding the especially management of the obese children, especially that our talk is dedicated regarding the dietary and lifestyle modification. So over to Dr. Bhavna.
Dr. Bhavna, you can share your screen. Yeah. Full screen, please.
Yeah.
You have to enable this editing first before you can make it full screen.
Are the slides available?
Please make them full screen. Enable this editing and then you can make it full screen, not before that. Just press on this enable editing. Click on this enable editing.
Yeah.
Yeah. And then make it full screen now.
Is it full screen?
No, it's not full screen.
This one.
Yeah, this is still it's not slides.
This one.
Enable it.
Sir, is it now?
No, yeah, now it is full screen. Right.
Okay. I'm really sorry, sir, for all these problems.
Fine,
Actually, some connection issue with at 2-3 places, so we are reconnecting with the other devices. So I thank Dr. Shyam Meena and IAP also to give me a platform to speak out. And my topic basically today is on prevention aspects of obesity. So as Dr. Smita has already given a very wonderful talk on the general overview and also about the management issues of pharmacological management. And also I must congratulate Ms. Shikha also to also give a very beautiful talk. And I really feel like that she is already having doing so much work on the basically the management of the PWS and creating a very good and very supportive group. And because her initially to start with, she had a child who has been affected, and she's now large scale doing for other children also. So that is a very wonderful thing. So over to my topic now. So basically, today I'm dealing with the basis of prevention. So that will include the lifestyle modifications at beginning very early, and also the present management lifestyle modification which are to be continued. The dietary changes which are to be incorporated in the child's diet, importance of the physical activity and the level of activity which is to be done. And that is because there is a problem. Every mother is coming and the parents are coming. What sort of activity that the child should be doing to achieve that maximum activity level. So that I will be dealing with, and also the screen time recommendation, because screen time also affects largely the obesity part. Then I will just touch upon the health, what are the different names of the health programs and the reduction targets which we are aiming for. And thirdly, little brief about the role of bariatric surgery for the management part. So the basis of prevention starts from the lifestyle modification. So it is starting very early onset, like during the conception of the child. The mother, the conceiving mother should be taking care of, and also the ongoing part, or what are the things that the parent should be telling and the parent should be doing with the child. Then the dietary modification or the changes, and the physical activity. Then there is a specific role of pharmacotherapy and surgery. They are not very important in the initial part, I must say. They do have an important part, but a little later, not initially. So whatever Dr. Smith has already touched upon the pharmacological part. So then to identify the maladapted family rearing practices and to prevent them, help the parents to basically to recognize that the child is obese, and promote the intra-family communication pattern which boosts the self-esteem. So the main problem that we are issues that we are facing with the adolescent and the children, that they are having a once the child is being labeled as obese, or the child is getting obese. So there are multiple issues the child is facing at the school level, the community level, and the peers with the peer group. So that identification that the child is and to accept themselves as obese, that's also a big problem. So we have to make the child having the self-esteem that this problem has to be identified first, and the child should be able to overcome with the problem and to have a positive outlook towards this problem. So early preventive aspects, they will basically be the prenatal and the preconception time. So we have to tell the mother who is going to be pregnant to normalize the BMI before pregnancy. So, and to cessation, have the stop any smoking or drinking by the expectant mother. So that also plays a very important role. Then she has to follow a particular diet plan as per the RDA for the recommended for the pregnancy and the lactation part. And we have to tell her to maintain a very balanced diet right from the beginning of the conception, to have maintain the micronutrient levels, all the particular recommended diet, correct amount of protein, calories that she has to take, and to avoid any excessive fatty food. Then she has to monitor the gestational weight gain. So initial weight gain she should not be overweight to begin with, and she should not be able to gain the weight suddenly also. So that is a risk factor for diabetes, the gestational diabetes, and the risk factor for obesity in the child later. Then there should be stringent glucose control for the mothers who is having GDM. Then in the postpartum and the infancy period, there should be promotion of the exclusive breastfeeding for the first 6 months of life, and total for about 24 months. Exclusive, the breastfeeding should be continued. Exclusive for the first 6 months, and should be encouraged for the total of 1 to 2 years. The child should be fed. The breastfed should be done. Then complementary feeding introduction at about 6 months of age, with the right amount of cereals, fruits, and vegetables should be included in the diet. Then meat intake should be lean, and poultry and fish should be there later in the first year of life. That should be done at the right time. Then we also recommend that there should be a low added salt in the food for the next 1 year of the child, and sugar intake should also be minimized for the next 2 years and should be minimum. And because we have a general tendency to have in our Indian setting, that child should be having excess of salt, the sugar in the diet, and excess of fatty foods right from the beginning to keep the child healthy. So that thing should not be done. Then there should be complete avoidance of the advertised market food preparations. Like all these companies are, advertising the Cerelac, the food preparations, the ready-made to eat food and everything for the beginning at 6 months of age to right from the 2 years, 3 years of age. That should be discouraged for the mother, and they should be told to be basically focus on the home-based diet for the children. It should be fresh, healthy, and home-based, and should be made by the mother herself or the caretaker herself. Then food habits which are having a positive correlation with obesity. First, that has to be identified. So this is in the older children. So this is basically a family-related issue. So family should be able to cut out these habits along with the child. Frequent dining out should be avoided first. Then high calorie intake of food should be avoided, and increased consumption of meat should also be avoided. Any sort of carbonated drinks and beverages, those are the main culprit or the risk factors which are nowadays the child are in the any parties that they are going, every time the children are having carbonated drinks, juices, etc. That should be discouraged. Then intake of ultra processed food is also having a risk factor for the obesity, and frequent snacking of the junk items, that should also be avoided. So what are the healthy lifestyle practices that has to be incorporated? And the family intervention is the first more thing which has to be done. Family has to be involved themselves. Okay, so the family has to be a role model. Family, the parents and all the elder members have to be a role model for the child. So this should not be taking place that we are restricting the child not to eat, but we are ourselves eating those things. So that should not be there. The whole meal should be like that the child and the family whole, they are taking the same sort of meal, so that the child is encouraged to eat the healthy foods. So regular meal at fixed times and fixed place. And we should not allow the child to skip any meals, because next time he's going to binge eat or overeat. Then television during the meal time should be absolutely avoided, and because that also leads to binge eating, and the child does not himself knowing or herself knowing how much he's eating. Then do not force the children to clean their plates. Do not use foods as reward, bribe, punishment. That should not be done. Food should be taken as an importance, sort of a thing, or an important time, meal time. And that should be, child should be, any sort of distraction or any other thing should not be with the meal time. So that should be avoided, and the child should be focusing on the meal itself. There should not be any force feeding of infants and older children, and they should be encouraged for hunger time eating. So they should not be overeating. For the smaller children, that we have a tendency that the child is not eating, the mother is always told, no, feed the child, feed the child. That should not be done. Child should be, for small children, you have to set the mealtime pattern, and how much recommended intake should be there, how much the child at which age, how much quantity has to be taken. Then forced feeding and self-feeding also, it should be done in regulated manner for the older children. They should be able to identify how much hungry I am, how much I have to eat, and what time, what right thing I have to eat. That should be done, right? So focusing on the home-made nutritious food should be done, and eating out should be minimum. There should be avoidance of the carbonated drinks, beverages, and packed juices. Then diet should be a blend of diverse food groups to provide the sufficient energy, and it should be in the right amount. The protein, fats, micronutrients, and vitamins in the optimal proportion as per the RDA for the age and the sex. And use of the RDA and estimated average requirement, that is ER, including the tolerable upper limit should be kept in mind, during the feeding time. And beyond 2 years, the adequate consumption of the dietary fiber is encouraged by eating a variety of fiber-rich foods, then and vegetable, cereals, and whole grain products. Then dietary guidelines, dietary changes which has to be incorporated along with the other lifestyle changes. Then as per the American Academy of Pediatrics and the US Department of Food and Agriculture, they have recommended that 3 things should be kept in mind. There should be decreased consumption of fast foods, sugar-sweetened beverages, high fructose corn syrup, saturated dietary fiber, fats, processed foods with having a very high sodium level. And there should be increased intake of dietary fibers, fruits and vegetables, and timely and regular family mealtime should be there. So we should be following the traffic light, red light, the light plan and dietary plan, in which there is a red light, the yellow light, and the green light. In the red light, they should be stopped. That is all complete avoidance of the fried foods, sweets, chocolates, and full processed items, red meats, etc., and fruit juices and canned products. Then in the yellow item, we have showing the products which should be taken in moderation, like milk and milk products, meats, eggs, cereals, bananas, mangoes, grapes, etc., roots, vegetables, sugar minimum, and fat content should also be in the recommended. The biscuits, bhutta, popcorn, etc., should also be eaten carefully. But in the green, all these mentioned items can be taken liberally. That is all the seasonal vegetables, green leafy vegetables like saag, raw vegetables like salads, all whole fruit, fresh fruits, fruits with skin, apple, guava, pears, seeds, and like anar and guava. Low sugar foods like fruits like watermelon, papaya, muskmelon can be taken, and fruits with pulp and fiber like oranges, kosambi, etc. can be encouraged. Then puff rice, roasted chicken, and fish should be there. It should not be fried. And salted lemon water can be taken in liberal amounts, vegetable soups and plain fresh water. So instead of any like canned products or the sugary juices, the child should be encouraged to drink salted lemon water as when he is thirsty, and a liberal amount of water intake should be there. Now, going to physical activity. So, how much should be physical activity should be there? The physical activity of moderate to vigorous exertion for a minimum of 20 minutes should be there, with the goal of 60 minutes in more than 5 years of age. So we have the set amount of exercising level should for the younger children also, which I'll be dealing in the next slide. So what is the benefits of exercise? Exercise reduces the visceral adipose tissue. It promotes the muscle mass and independently reduces the risk of cardiometabolic complications, improves the motor and cognitive development, psychosocial well-being, skeletal helping, and overall risk of mortality is decreased. And the physical activity should be taken both as an aerobic and an anaerobic exercise should be combined with each other. So for the infant, toddler, and preschoolers, they should be encouraged to remain active throughout the day, throughout the age appropriate activities and playtime. So they should not be strapped or kept in the prams and all. They should be freely encouraged to move as much as possible. And an average of at least 60 minutes to moderate to physical vigorous activity should be spread throughout the day. That is recommended for older children and adolescents from 5 to 17 years of age. And this should be including the high intensity training or the resistance exercises in 20 minutes a day should be incorporated at least 3 times a day for strengthening the muscle and the bone and the bony part. Then besides the planned activity, they should be freely allowed to engage in daily course, activities, sports, recreation, role play, etc. and team play. So that should be done. For the school, it is recommended that the school should be having a 30 minutes per day school active physical activity program in the school. That should also be done. Now, what is the role of community and schools? How can we contribute as a doctor and a doctor, because these children are coming to the pediatric endocrinologist. So we can identify these children, tell them for counseling, give them get a testing done, whatever management has to be done. But as a role for the schools and community, we have to increase the family-friendly exercising for these children and provide a safe play and facilities for the children. And we have to mandate a minimum standard for physical education in schools and homes, and review the contents of basically all these food fads and advertising. They are coming up. So the adolescent and the older children, they are into it. And so we have to tell them or make them aware of these things that are going on in the market. We have to review the contents, whatever vending machine the children are going through and they are accessing. We have to replace them with the healthier choices and tell the children and inform the children. Then food label policy should be there to, there is enough evidence to support that good and responsible food labeling can reduce the burden of obesity by guiding the customer to buy the right amount of healthy food by influencing the behavior patterns. So there is also a particular role of adequate sleep also, because if the child is having deprived sleep and that also is a risk factor or a contributory factor to obesity. So there is evidence to support an association of inadequate and poor quality sleep with the risk of overweight and obesity. So what is the recommended sleep? So from 0 to 5 years, it is said that the children should be having 11 hours of sleep pattern. They should be there at least. And as the child grows older, it is little lesser, that 5 to 10 years, we have at least 10 hours should be there. And 10 years and above should be at least 8 to 9 hours of sleep, adequate sleep for the general well-being and the overall health. So now there is also a recommendation for screen time, and screen time for it is as per the IAP and the Indian Ending Childhood Obesity, we have different guidelines, but it is almost similar. That is, there is no more than 2 hours per day for children who are more than 2 years of age, and children less than 2 years should not be watching any amount of television as per the recommendations of the IAP and the IAP. So meal time along with the television and the mobile media, they should be discouraged. And this may lead to overeating. So that has to be not done mixed along with the meal time. So Ending Childhood Obesity, WHO has also released the recommendation, and that should be under 5 years. There should be no screen time for children under 1 year, and should not be more than 1 hour for children under the age of 5 years. So that is almost similar, but slight variation is there. Then in the 10 to 18 age group, it is advised to balance the screen time with other age-specific developmental needs. This will include the recreation screen time as well as time spent on the screen to complete the education assignments, and should be mainly used for the academic purpose only. They should not be minimized for the recreation purposes, and child should be encouraged to having more outdoor play rather than sitting, in front of the screen and binge eating. So the ideal BMI reduction targets is that by keeping in mind the intensive family central lifestyle modification, which includes the dietary, physical, behavioral, and they are effective tools to decrease the BMI. They are used in combination. And goal is to even that a moderate decrease in BMI by about 1.5 kilogram per meter square, or a 7% loss. For those having an extreme obesity, having a favorable effect on the SBP and the lipid profile. So that is having a effect on the parameters also. So reduction of BMI by 1 unit can decrease the systolic blood pressure by 1.25 millimeter Hg and the serum triglyceride by 1.5. And reduction of weight by 1 unit also increases the serum HDL level, which is a good cholesterol, by 0.55 milligram per deciliter, and decreases the triglyceride by 2.8, which is a significant reduction. Now, the role of the food industry also plays a role that they should be having a proper nutritional labeling for the food products. The red and green light food labeling should be there, and we should be aware of these facts. And they can reduce the portion size, for the children, and that can be making a difference. For the healthcare provider, what can the healthcare providers do? They can work towards the classifying the obesity as a disease. So basically, now it is going to be an epidemic. Over the time we have seen a twice, fold of rise from the 2.8 to 4 point something. Like there is a rise in the obesity prevalence for the last few years. So we have to identify that is as a disease and to promote or recognize these factors in the child. So first thing is to that, and then these child can be referred to a proper care center. Now we have a rule of 5 to 1 0, that is a healthy lifestyle counseling for the parents. We can be doing that. That is 5 fruits and vegetables per day should be taken, servings in different time intervals. There should be 2 hours of less of screen time, and then or one and more physical activity, 1 hour or more physical activity per day, and 0 sugary drinks throughout the day. So that should be there. Now the public health programs have been launched, various programs for to implement or to address the obesogenic environment in the children, as Dr. Smita has discussed, and critical period in the life course based on the recommendation of the Commission on Ending the Childhood Obesity that was launched in 2016. So WHO is also working through it as the Global Action Plan on Physical Activity till 2018 to 2030. It provides effective and feasible policies to increase the physical activity globally across the world. And there are many regulatory bodies, provision of the financial incentives to the food industry for promotion of healthy foods, which they should be banned on the advertising of the non-nutritious food, and financial support to urban planners for establishing more areas for jogging, bicycling, and walking paths. Then NRHM school programs are also working towards it. Their community level programs at Chetna Amar are also working for the holistic approach for prevention of obesity and diabetes, and now covering over 5 lakh children in 15 towns and cities across North India. Now, FSSI has also eliminated the trans fat in the supply by the food by 2022. There was a program launched, and now the Eat Right India movement has been launched on 10th of July 2018 for the promotion of the nutrition balanced eating. Now, there is an IAP initiative which I would like to mention, launched in September 23. That is a Sankalp Sampoorn Swasthya SSS program, which is a community-facing school-based holistic healthcare national initiative with a focus on the non-communicable disease particularly. And they are the focus is on the and the aim is on the empowerment of the school for health promotion of students through a standardized protocol, and mainly focus on the primary prevention aspects. Now, now just a few lines, I think, for the surgery. The surgery, the indication are specific. After completing all the preventive, we will go to the surgical. The pharmacological has also been dealt with by Dr. Smita. So I'll be just brief touch upon the surgical aspect. What are the indications? The patient who is having BMI more than 40 kg per meter square or 35 kg per meter square with a significant comorbidity. Those are the patients who are being labeled for the or being marked for the surgery. They will, if they are persisting despite a formal program of lifestyle modification, with or without a pharmacological therapy for more than 6 months. These are the candidates for the surgical management. Now, what are the prerequisites? The child should be able to attain the skeletal maturity with TANF 4 or 5 pubertal development. There should not be any underlying substance abuse, eating or psychological disorders. And patient demonstrates ability to adhere to the principles of healthy lifestyle changes and habits and exercising. That should be able to continue after surgery. Now, the procedure basically are 3 types. That is the LAGB, laparoscopic adjustable gastric banding, the RYGB, that Roux-en-Y gastric bypass, and the VGS. The last 2 are the more common ones which are being done. And now these, what are the benefits of surgery? That even when the obesity persists, there is a improvement in the comorbidities following the surgery. They can be malabsorptive type of surgery, which will decrease the mucosal function by rearranging the anatomy. Second is the restrictive surgery, which is the resection of a part of stomach or a vertical sleeve, gastrectomy, or placing a silicone ring at the entrance of the stomach, which is a LAGB. And a combination in which there is a little surgery or a bypass surgery, which can be done. That is a Roux-en-Y surgery. So these are the just to explain. The LAGB has in which there is a banding can be done. And this in the LAGB, there is however, there is a high risk of reoperation and long-term complication. And it is not really used nowadays. So VSG is more commonly used, in which there is a part of the stomach, the upper part and the fundus and the greater curvature, they are being resected. And this has a lesser complication or malabsorption or post-operative obstruction, so mostly preferred. And third one is the Roux-en-Y surgery, in which there is a higher chance of dumping syndrome and malabsorption because of the reduction in the surface area of the mucosal, and there is a low gastric secretion after the surgery. And there is a risk of iron deficiency and a B12 and a folate deficiency, which is seen afterwards. And vitamin D levels absorption are also affected. So that has to be kept in mind after surgery, and supplementation has to be done. Both the RYGB and the VSGs decrease the oxygenic hormone renin and increases the incretins GLP-1 and peptide YY. So they will suppress the appetite and improves the insulin sensitivity, which having a long-term benefit. So how do you monitor the surgery benefits? That is measuring the percentage of total body weight, changes in the BMI, and the expected BMI loss are the main methods to evaluate the success of the surgery. And persistent of the comorbidities like type 2 diabetes, hypertension, and or hypertension is considered as a failure and indication for the revisional procedure or a resurgery. Now, common with VSG is the GERD, erosive esophagitis, and Barrett's esophagitis. Deficiency, as I've told, of vitamin minerals because of restricted nutrient intake, decreased gastric production, and food intolerance because of dumping syndrome. There is a decreased bone mineralization is common, and because of the Roux-en-Y gastric surgery, decreases the cholecalciferol absorption by 25%, and concentration of calcium and phosphorus may be low. So annual monitoring of the deficiencies and the micronutrient supplementation should be taken daily, and that is recommended after surgery. So what are the take-home messages that we should be keeping in mind? That the combination of dietary changes, lifestyle modification, and physical activity are key to prevention and reduction in obesity. There should be full parent support and family guidance, which is playing a major role in the management of reduction of obesity. And identification and acceptance of the obesity by the parent should be there, and the child. That is of utmost importance for the beginning of the wishful positive outcomes, and involves a multidisciplinary approach. And surgery has a specific but a limited role. And after knowing the risk factors and the criteria, who are the candidates going for the surgery. So with that, I end my talk, and I thank IAP for this, giving me the opportunity. And over to Mukesh, sir.
Wonderful talk, Dr. Bhavna. We definitely agree that the role of diet and the lifestyle modification is the paramount in the management of obesity in children or adults. Comments from our Lalit sir, Dr. Smita, Dr. Shyam Sundar.
Just want to know what is the experience. Somebody has the experience. How many patients are normally being referred for bariatric surgery? It's being done in children. I have heard in adults being done. It's being done at what age? And how are the results in Indian population? Somebody can comment on this?
Hello.
My audio.
The voice is cracking too much. I'm not able to make out who is talking. Let me try to figure it out.
It's okay. Now it's okay.
Sir, you're audible now.
What is the experience of bariatric surgery in children in India? Do we refer patients? Are there candidates who require surgery? There must be. I think any experience with somebody, any data we have.
So,
Anybody can comment, Sunita or Dr. Bhavna. Anybody can.
So basically, not many candidates, because usually in my setup, usually we counsel for the as per the lifestyle changes modification. Only those few candidates are there, and usually the surgery is indicated after 12 years. So there are not many, but definitely they can be going. And in our center, they are not being like much started, but in private centers, etc., they are being taken, and the child can stick to the diet plan and the changes later on. Then the surgery might have a benefit.
So it is done after 12 years, basically. Majority.
So after, usually in the older age group, not sir, in the less than 12, it is not usually done, not indicated.
Okay. Thank you.
Sir, I would also like to add here, in our community of PWS, there was a child who underwent by bariatric surgery, and she passed away due to stomach rupture. So in PWS, from PWS point of view, bariatric surgery is not at all recommended, even international standards or in India. Just wanted to fill you all about this.
Point well taken. Noted. So, Dr. Sham, would you like to add something? Dr. Smita?
So bariatric surgery, there are only sporadic case reports. Most of the times when they're referred, even in childhood, like Dr. Bhavna said, after 12 years, a lot of time there is an underlying cause like a monogenic obesity, which is not controlled by lifestyle and pharmacology. So you have to remember that when somebody, you reach the stage of obesity, third stage with life-threatening side effects, severe comorbidities, once you've tried everything. So a lot of time these are when there is usually a monogenic cause or something like a genetic cause, because other than that, the PWS hypotonia itself does not favor surgeries. So like she was saying, so surgery is very limited and then very, very sporadic cases, not the first, second, third, or the fourth option.
Yeah.
Right. And Shikha, any PWS patient being referred for this surgery? It's basically that's a genetic cause. It won't be useful in that case.
Yes, PWS patients strictly should not go in for bariatric surgery because it's the malfunction of the hypothalamus. So it has nothing to do with the stomach being cut into short, smaller stomach. So in fact, it is very lethal, very fatal for a PWS child to go into. We have seen one case in Bangalore where we've lost a child.
Okay, thank you.
Fine.
Thank you very much.
So any more comments? I don't see any questions in the chat box. So if there are no more questions and no more comments, can we close this session? Right. So thank you, Dr. Smita. Thank you, Mrs. Shikha. Thank you, Dr. Bhavna. Thank you, Dr. Lalit Mandirata, for being a part of us, for part of this obesity awareness webinar. And thank you all. Take care. Good day.